Thank you so much for viewing the presentation. This is a talk that I gave at the 2024 Fetal Heart Society meeting at the Phoenix Children's Fetal Cardiology Symposium, and it is a section of the American Society of Fetal Echo Guideline in 2023 on progressive lesions in the fetus. And so when we talk about progressive lesions, we're talking about lesions that first may appear mild, but then evolve or progress into more severe structural and functional heart disease in the fetus throughout fetal development. And this is table 14 in the guideline, and it highlights the mechanisms and patterns of progression in certain types of fetal congenital heart disease. You can see in the center column, there's a very thorough list of the types of defects or heart disease associated with the evolution and progression of the heart failure. The column on the left is specifically listing the progressive mechanisms, and then you see on the right side is the end result of the evolution and levels of severity commonly caused by the lesion that is a progressive lesion. And so why do we follow these fetuses serially and so closely? Well, these fetuses are particularly at high risk for cardiovascular compromise. So we need to evaluate them serially to monitor for this. And there also needs to be a robust postnatal care plan in place. Are we going to need an immediate postnatal intervention for the fetus, or do we offer the family comfort care? Will there need to be an early delivery? And if so, will the delivery hospital be equipped to handle these very sick babies? And some of these babies will unfortunately not make it to term. Some fetuses may be eligible to receive fetal cardiac intervention, and this includes fetoscopic laser photocoagulation therapy for high output lesions such as twin-twin transfusion syndrome or TRAP sequence. Balloon valvuloplasty is another option that we can give to these fetuses if they have a similar valve outlet obstruction like pulmonary valve or aortic valve critical stenosis, and septoplasty for those who have left atrial or pulmonary venous atrial outlet obstruction. And for fetuses with incessant arrhythmias, we can offer pharmacotherapy that's delivered through the mother and transplacentally. And finally, the recommended follow-up intervals vary between institution and also based on the type of progressive lesion. One of the most striking examples of a progressive lesion is Epsteins anomaly and dysplastic tricuspid valve. In this fetus that's 13 weeks along, we can see significant right atrial and right ventricular enlargement, and this is caused by severe tricuspid valve regurgitation. But in such a short amount of time, you can see clearly the progression of cardiomegaly with a profound increase in the cardiothoracic ratio, and this can be a very valid prognosticator of the postnatal course of these very sick fetuses. Now this is table 13, and it's a very detailed and helpful guide to disease-specific targeted assessments for the most commonly encountered progressive fetal congenital heart lesions. And it breaks down these assessments based on the defect type and level of severity. Things like key observations, common venous Doppler variations, specific associated atrioventricular valve issues, what to expect when imaging outflows, additional measurements, and other key assessments. And using this very helpful guide as a tool when evaluating progressive lesions helps ensure that all the components of the exam are performed, and the values are documented for comparison during your follow-up serial exams. This is a great example here. Critical aortic valve stenosis, severe left ventricular and left atrial enlargement. You can see endocardial fibroelastosis, very poorly functioning left ventricle, but this becomes a very essential piece of your evaluation as a guide to evaluate the same values each time you're evaluating this fetus. So you can compare mitral valve regurgitation velocity, pulmonary venous forward to reverse ratio, aortic valve stenosis velocity and gradient, middle cerebral artery, aortic arch transverse, aortic arch reversal, flow reversal, and this is the atrial left to right atrial shunt velocity here shown. And so you can see how this can help you guide you through your examinations to hit each one of these components every single time you evaluate this fetus. Now this is table 15 in the guideline, and it highlights the recommendations regarding imaging-based risk assessment and follow-up imaging for specific diagnoses, including those which are known to be progressive. It lists indications for follow-up imaging, suggested follow-up intervals, key imaging findings to assess, and a very thorough list of example diagnoses. And so this is an example of a fetus that we followed in a serial fashion for a critical aortic valve stenosis lesion. And so at first we saw the fetus, 23 weeks gestation, and we can see in this mid-thoracic axial view, 4-chamber, that the left ventricular function is severely decreased, very diffuse hypokinesis with endocardial fiber elastosis here shown with this echo brightening. And when we turn our attention to the aortic valve, indeed we did see critical aortic valve stenosis with a very small jet of accelerated flow here, and then mild mitral valve regurgitation. Looking at the continuous wave Doppler gradient or velocity through that aortic valve told us that the left ventricular function was actually not as bad as we thought. It was generating a pretty high pressure with a peak velocity past 3 meters per second. And then looking at the mitral valve regurgitation velocity again helped us understand that the LV was generating quite a good pressure even though the function looked terrible. Mitral valve inflow pattern was the typical short duration, monophasic mitral valve, high pressure, high filling pressure pattern. But the pulmonary venous tracing looked okay with very little pulmonary venous reversal because there was a decent left to right atrial shunt. Looking at the transverse aortic arch here in the 3-vessel tracheal view, confirmed our suspicion that there was a severe left outflow tract obstruction with this reversal and systole through the transverse aortic arch. And so based on this information, we thought that this fetus was a good candidate for fetal intervention, and specifically aortic valvuloplasty. And so we sent this fetus to a center that would do this, and here you can see the interventionalist getting access through the fetal apex here of the left ventricle, through the fetal chest with the needle, and then forcing the needle through the fetal chest here into the apex, and then passing the catheter up toward the left ventricular outflow tract, and then a balloon catheter is advanced through the aortic valve, and balloon valvuloplasty is occurring here. And so 4 weeks post-intervention, we saw the fetus back at 27 weeks gestation. And the left ventricle actually became more globular and did not appear to be functioning any better than previous to the intervention. Looking at the aortic valve outflow, you can see it's still accelerated here. There's no aortic valve regurgitation, which is something that we are concerned with when we perform a aortic valvuloplasty. Sometimes you'll have residual aortic regurgitation from disruption of the valve. But this velocity was much less than previous to the intervention, and this was actually promising, except when you looked at the mitral valve regurgitation velocity, it was also decreased. And this told us that the left ventricular function had decreased more, and the left ventricular forces were diminishing. And so this was not a good sign for us. And so at 8 weeks post-intervention, we saw the fetus back and at 32 weeks gestation, and you can see that the mitral valve inflow pattern has now almost normalized with a biphasic appearance, but the aortic valve outflow velocity and mitral valve regurgitation velocities both continue to decrease in their value. And so when you actually look at the left ventricular apex, there was evidence that there was significant truncation with the development of hypoplasia of the left ventricle. And so this fetus went on to receive a single ventricle palliation, which is the Norwood procedure. And so this is recent research on the assessment of progressive pathophysiology after early prenatal diagnosis of Epstein anomaly or tricuspid valve dysplasia. And so the aim of the study was to serially evaluate whether echocardiographic indexes in fetuses with Epstein's or tricuspid valve dysplasia, and also with relatively low risk anatomic physiologic findings at less than 24 weeks gestation, are reliable indicators of physiologic status later on in gestation. And what they found was that most of the variables used in the serial evaluation of these cases were very accurate predictors of progression severity and associated with higher perinatal mortality. And so in their conclusion statement, they stated that it was imperative to serially evaluate the fetuses and develop a later gestation management and delivery plan for the family, as well as discussing the regarding appropriate surgical interventions needed and innovative or experimental prenatal interventions that could be done. Now, this is a good example of a fetus that has significant heart disease but looks normal in the beginning. Here at 22 weeks, we saw this fetus was sent to us with slightly enlarged right heart, and you can see here indeed that there is right atrial enlargement, mild right ventricular enlargement, but things look okay in terms of this four-chamber view. The tricuspid valve looks like it is a normal tricuspid valve, but when you apply color Doppler to the tricuspid valve, you can see at least moderate regurgitation. And looking at that velocity jet through the tricuspid valve, we can see that it's within a normal range for a normal right ventricular systolic pressures. And so we turned our attention to the right ventricular outflow tract and pulmonary valve, which would be the most likely cause or mechanism of that significant tricuspid regurgitation. And you can see here in this three-vessel tracheal view, here is the SVC, the aorta, and here is the pulmonary valve. You can see that the pulmonary valve leaflets are moving, but that the size of the aorta and pulmonary artery are discrepant. Pulmonary artery is smaller than it should be, and the pulmonary bifurcation shown here, and then the ductal arch is actually faintly shown here. So we applied color Doppler to the RV outflow tract. Here's the pulmonary valve with antegrade flow, nice and laminar, low velocity flow through the pulmonary valve, and the ductal arch here, all blue, which they should be. This is aorta, it should be blue as well, and so we saw that that was a normal appearing flow pattern. And specifically with pulse wave Doppler through both of these structures, pulmonary valve and ductal arch, we see that they're normal antegrade flow patterns with normal velocity. So we could not describe why that was happening. But here at 35 weeks, we see another increase in the size of the right atrium here. The tricuspid valve is clearly looking more dysplastic now, and when we apply color Doppler, we can see severe tricuspid valve regurgitation, again with a very broad vena contracta here. And so again, we were concerned that the right ventricular outflow tract was affected as well. But we first looked at this velocity through the tricuspid valve regurgitation, and we can see that it is reaching almost 3 meters per second, which is significantly more than the previous fetal echo that we had performed. So here, looking at the upper axial upper thoracic view here through vessel tracheal view, here's SVC, aorta, and pulmonary artery, and we're looking at the pulmonary valve there, and it appears to be moving, but we're not sure, so we apply color Doppler. And this pattern here, this red, is retrograde flow through the ductus arteriosus, which is not normal. And so we evaluated that, and indeed we could see that it is continuous retrograde flow through that ductus arteriosus, turning our attention down now toward the pulmonary valve. We can see all retrograde flow through the main pulmonary artery into the pulmonary valve with continuous pulmonary valve regurgitation, shown here with this Doppler pattern, all systolic and diastolic regurgitation, continuous regurgitation pattern, which signifies a type of circular shunt. And so briefly what we'll see is with a circular shunt, regurgitation through the tricuspid valve here, which passes right to left through the foramina valley, back through the left ventricular inflow. Left ventricle then ejects this flow out the aorta, and then that flow goes and flows retrograde through the ductus arteriosus and back through the pulmonary valve into the RV by means of pulmonary valve regurgitation, causing this circular shunt physiology. And the reason why this is important is because these fetuses usually have a poor outcome. The same fetus, looking at the abdomen, you can see the development of ascites. And then looking at the ductus venosus tracing at 22 weeks appears normal, 27 weeks slightly abnormal with this more of a mid systolic notching here, and then the A wave has not reversed, but then clearly at 35 weeks we see A wave reversal on all of the cardiac cycles. The umbilical artery and umbilical vein, again, normal at 22 weeks, and at 35 weeks, umbilical venous notching here, shown at end of diastole with atrial kick, and the cessation of antegrade flow in the UA during diastole. Tetralogy flow with absent pulmonary valve is a progressive lesion that has among the highest rates of morbidity and mortality, but is highly variable in its clinical presentation. This is recent multi-center research that was referenced in the guideline on contemporary outcomes in tetralogy of Fallot with absent pulmonary valve after fetal diagnosis. And what they found was that the overall predictors of increased fetal mortality were the development of ventricular dysfunction, specifically right ventricular dysfunction, as well as the presence of mediastinal shift caused by the secondary effects of airway obstruction. And so what they concluded in their conclusion statement was a comprehensive assessment of fetal heart and lungs can predict outcomes in tetralogy of Fallot with absent pulmonary valve, guide prenatal counseling, and perinatal management. Now, this is a fetus that we saw was referred to us and had an MRI that was done before our visit. And so they were referred by the maternal fetal specialist with tetralogy flow with absent pulmonary valve and a possible brain abnormality. And so this MRI was for the brain assessment. But when you look at the diaphragm on these fetuses, which we do look at in fetuses with potential airway obstruction, we can see that the diaphragm configuration in this fetus has a normal appearance, a normal contour. And so this is important, even though the heart was not very well imaged in this MRI. So at 29 weeks, we were able to see the fetus in our lab for the first time to do a fetal echocardiogram. And you can clearly see in this 4-chamber view that there is mediastinal shift leftward with a more leftward axis, right atrial and right ventricular enlargement. And then looking here, you can see aortic override of this large VSD. And as you sweep more cephalad, you can start to see a dilated RV with a RV outflow tract here, giving rise to this very rudimentary and non-existing pulmonary valve annular region here. Pulmonary valve is non-existent, it's just rudimentary tissue there, sort of a napkin ring deformity of that RV outflow tract, and a very pulsating, dilated main and branch pulmonary artery appearance here. With color Doppler, you can see a high velocity antegrade jet through that pulmonary annular region and severe pulmonary valve regurgitation. Turning in a sagittal view or perisagittal view, you can see the spine back here. This is descending aorta. You can clearly see the RV outflow tract here with the severe pulmonary valve regurgitation. But what you need to really focus on is how pulsatile this pulmonary artery, main pulmonary artery and pulmonary branches are. And when you look with 2D, you can see the airway here and how pulsatile this pulmonary artery is, pushing on that airway and causing airway narrowing back here posterior to the main pulmonary artery and branch pulmonary arteries. And so this creates this obstructive physiology with the airway and fluid trapping in the lungs. And so we were concerned that this fetus might be suffering from airway fluid trapping in the lungs from the airway compression. And when you look at the diaphragm here, you can clearly see that the diaphragm is inverted due to excess fluid trapping. This finding provided us the information we needed to counsel the family appropriately regarding potential likelihood of a poor postnatal prognosis for their baby. So to summarize, serial follow-up evaluations provide accurate predicted outcomes in these fetuses. Remember to use your targeted evaluation specific to the lesion, and this allows you to do serial comparison of the components for more accurate following of these progressive lesions. The cardiothoracic area ratio is very important in these fetuses, and remember that progressive cardiomegaly predicts the outcomes. All abnormal cardiac axis and position in tetraatrial fluid with absent pulmonary valve syndrome may indicate fluid trapping. Significant postnatal airway obstruction can happen in these fetuses with poor ventilation, which leads to poor outcome. And Doppler is crucial in this evaluation of these progressive lesions, and specifically for serial assessments and comparison. Remember that flow direction through aortic valve or aortic inductal arches and atrial septum are components that should be evaluated. Pressure gradients to evaluate stenosis severity and ventricular function can be indirectly evaluated through these assessments as well. And venous and ventricular inflow patterns and time intervals are also very important components of most of these lesions. Thank you very much.